I'm really excited to be sitting across from you today because you died.
I did. I had a cardiac arrest in my sleep, and my wife did 10 minutes of chest compressions. The fear afterwards was something unexpected. I was afraid of being alone anywhere. It wasn't just me. My wife, I would wake up in the middle of the night to find her checking to make sure I was breathing. She would check to make sure the kids were still breathing, and they were fine.
Why did your heart stop?
Yeah, no, it's a good question. I get asked that a lot. I don't know, and nobody knows.
Welcome back to the Checkup podcast. My guest today is Dr. Will Flannery, an ophthalmologist and one of the most successful doctors on social media. Will has amassed millions of followers by making comedy videos about different healthcare specialties, all under the handle of Dr. Glaucomflecken. If you work in healthcare, there's a very good chance he's made a few funny jokes about your specialty, mine included. When I ask my fellow medical professionals who they like to watch online, they always say it's Doc Glock. Considering he's maybe the most trusted and beloved medical influencer in the eyes of my peers, I wanted to speak to him about how he got his start, the mistakes he's made along the way, and the mistakes he sees others make who try to follow in his footsteps. He also opened up to me about his incredible frustration with the American health insurance system. It not only impacts his patients on a daily basis, but has caused him and his family incredible personal stress when he was recovering from testicular cancer for the second time. Oh, and the day his heart stopped. Yeah, did I forget to mention that? He literally died. You know what? Let's start there. Please welcome the very much alive Dr. Will Flannery to the Checkup podcast. I'm really excited to be sitting across from you today because you died.
I did.
Yes. You died, and yet you're
Briefly.
here.
Yeah.
Yeah. So not only are you a physician, but you're someone who's had to deal with many physicians across your life for the death, near-death, semi-death experience.
I think it's like 99% death.
99% death.
On the brink. Yeah.
A cancer diagnosis.
Yeah. Yeah.
That's a lot of things thrown at one person who's in the medical space as a physician. Was it easier for you to go through all of this knowing what you know from your career, or did it make it even more frustrating?
Oh, I'd say it was definitely easier.
Okay.
Yeah, going through it as a physician, just because I just had a sense of how the system works. I learned a lot about the medical system, actually, and being a patient. Really, for the first time, I dealt with a lot of the insurance side of things with my cardiac arrest. So back in 2020, in May, had a cardiac arrest in my sleep, and my wife did 10 minutes of chest compressions. And the recovery from that, I always tell people, was fairly straightforward, to be honest. Like I went to bed one night. I woke up in the ICU a couple of days later. Really, I didn't know what was going on. It was my wife that lived through all of that, right? And so when I say it was easier for me as a physician, it was infinitely harder for my family, because they were going through something that they'd never seen before. Obviously, my wife had never done chest compressions on anybody. And so it was big challenges for them. And then together we went through all the healthcare system issues.
And I know you say it very casually now because you probably said this story numerous times. I've heard it when we were working together, American Heart Association, amongst other times. But that's heavy in terms of not just a medical diagnosis, to have your heart stop, wife perform CPR, wake up in an ICU, but then also coming back from that. While you may not have known what happened, were you having fears that this could recur?
Oh yeah, I was. The fear afterwards was something unexpected. I was afraid of being alone anywhere. I never would have gone somewhere to speak at a conference because I'd have to be in a hotel room by myself. That lasted for months. And it wasn't just me. My wife, I would wake up in the middle of the night to find her checking to make sure I was breathing. She would check to make sure the kids were still breathing, and they were fine. And so the fear took a while for that to kind of dissipate. And at this point, I don't really think about it. For a long time, I thought about my cardiac arrest. I thought about it every time I exercised. I thought about it every time I just moved a little too quickly.
I'm sure if you felt a little twinge in your rib or something.
Yeah, exactly. Or when I, take a shower, I'd feel my defibrillator or the leads, going into my chest. And so, but that over time, it just became a new normal.
Mm-hmm.
And life is still different for me and my family, but we've kind of settled into this new normal for us.
Given that there were so many issues with insurance companies dealing with bookings, caregiver support, traumas, how is the healthcare system specifically tailored or perhaps unprepared for helping you deal with those mental challenges? Did they ever check in and ask you questions about your mental health, or was it just, okay, you're getting a defibrillator, this is the plan?
No, not really. And I honestly, and maybe this is more of a personal flaw, I didn't seek any of that out, because my thought was
that's a lot of patient pressure you're putting on yourself.
It is, and I'm not saying it's the right thing to do. Definitely not, because I can't tell you how many times my wife's like, you need to talk to somebody about this.
Yeah.
And that's part of my personality. I'm generally actually a very introverted person, and as physicians, one of our big flaws just generally is that we're perfectionists, and sometimes we try to do too much, or we think we can do too much on our own. And so, I have received help from people, and it's honestly what we talk about more at this point now, years later, is this issue of co-survivorship with my wife. She's a big advocate for this because a lot of attention was placed on me. Yeah, no one, asked if I, needed to see someone, mental health wise. I can't even remember receiving any documents or, brochures or anything.
If they did, what would you have said?
I would have thanked them for the information.
I love the brutal honesty.
I would have thanked them for the information. I probably would have said, yeah, let me think about this.
Okay.
And to be honest, probably wouldn't have thought much about it. Mm-hmm. And I probably should have. Mm-hmm. But what I think is very interesting about this story is that through the cancer diagnoses that I received, testicular cancer and the cardiac arrest, nobody ever thought to ask my wife how she was doing. That to me is just as alarming. As far as just how the healthcare system operates. Because as you know, when someone responds to an out-of-hospital cardiac arrest, usually it's a loved one. And we're always asking people to do CPR, learn how to do, we have taught how to do, people how to do chest compressions. But we also need to be giving people support when they do it, because it's a traumatic thing to do someone. On a mannequin's one thing, right? But doing it in person to somebody, especially when you're not in the healthcare system, you've never seen that, you've never done it. That's hard.
And this goes probably further than just cardiac arrest scenarios. So when someone gets a terminal cancer diagnosis, a hospice diagnosis, people that are around them are just as impacted, if not more so.
Oh, yeah.
And while I think there's definitive reason to blame the system, what I hope doesn't happen, because I've seen this weaponized by people who don't like doctors, where they say it's the doctor's failure that this is happening. I think it somewhat puts an unfair burden on physicians to say, okay, we need you to diagnose, we need to create some sort of relationship with the patient. We need you to diagnose this scenario. We need you to give a differential. We need you to give treatments, treatment options, institute those treatments, reassess those treatments, write your notes and make sure it's documented, fight for the insurance company. And then, and you didn't ask how someone else in the room was feeling. It's a lot of things we're putting on a single individual's plate.
Absolutely.
And I'm thinking of, how do you envision a world where the system can be better at that while still not necessarily physician blaming for all these problems?
Yeah, I think to that point, that's a great point. I think you listed like 57 different jobs, something like that.
And that's probably undercounting.
Right. There's probably a few more you missed. In the moment, it can be so simple as like offering someone a cup of water,
right?
Warm blanket, right? So that's really sometimes all it takes to make someone feel better about the healthcare system in general, is that those little, really quick, small personal interactions. But honestly, I think we need to give patients, a framework of how to think about themselves as a co-survivor of medical trauma or medical illness, and give them that agency. Let them know, like, okay, these are the things that you can do to help your family member, to help yourself. Questions to ask. We are so focused on the patient because we have to be. It's our job.
Rightfully so.
And so I think, us doing small gestures, but also giving patients' family members, this, kind of inside information, like, okay, these are things that you can think about and that could help you, how to organize your thoughts, how to, because in listening to, Kristen talk about her experience, she had trouble just thinking and collecting her thoughts, and in the state of grief. I didn't die, but I mean, almost did. And that just going through the trauma of that, we need to help people navigate that.
Yeah. I think about it in the ways we have certain checklists where a person, let's say, is admitted to the hospital. We have these transitional of care visits. In primary care, we do this often. So when a patient is discharged, they have a follow-up within 2 days, 7 days, 14 days. We have different structures based on how long they were in the hospital. And they're supposed to follow up. And we have a nurse call in, check in on them, schedule the appointment. And it's part of the checklist of what we do. And sometimes these checklists can become invasive and problematic. But I think a good checklist item to include, like when someone has a heart attack, for example, part of the rehab process is getting them into cardiac rehab. That's just, they have a set number of visits with cardiac rehab where they progressively increase the tolerance that their heart can take on. But here, one of the checklists is, did we check in with the caregiver that's supporting that person? Did we give options at the very least? And I don't feel like that's ever been discussed until I've heard it with you guys.
Yeah, it's such a important part of advocacy, for what we do, because seeing what it does to family members, and navigating the healthcare system just by yourself as a patient is hard enough, and even doing it in a group is, putting your heads together, trying to figure this out is really challenging. So
how did you handle this conversation with your children?
Little by little, they were 5 and 8 when the cardiac arrest happened, and fortunately, they did not, on the 911 call, Kristen told the dispatcher, my kids are in the next room. I don't want to scare them. That was what she said. And the dispatcher told the team that responded. They came upstairs, and one of the paramedics gently closed the door to their room. And we found out after we met with them a few weeks later, was that that first responder had made eye contact with our oldest daughter and just sitting upright in bed. Something that she still remembers. And fortunately though, because of what that paramedic did, they did not actually see me being carried by their bedroom downstairs. And then over time, it's been slowly, answering questions in an age, in a very age appropriate way. So, in the moment it was dad got sick, he had to go to the hospital. And then I think the next question after that was, Mom, what's for breakfast? So, it's
the resilience is strong.
Yeah. And then over as they've gotten older, because 5 and 8, that's pretty young.
Yeah.
As they've gotten older, they've asked questions. It's like you can tell that they've been thinking about it for months sometimes. And it's like, what was wrong with his heart? Do I have something wrong with my heart? And then you just answer him truthfully. And they, as they age and they become more mature and they can process, the severity of some things that happen like that. But it's been a process. A lot of people think that, you survive, you go home after a few days. That's great. That's the end of the story.
Yeah,
Everything's
exactly.
back to normal.
Yeah.
No, we're still still things come up.
Precautions and
And
thoughts about
just
the future.
and thinking about it. Yeah. And like what could happen to me when I'm 4 years old. And so those conversations still come up. And now we're, almost 6 years out.
I'm not asking the question because I'm somewhat aware, but I feel like I'm doing a disservice to the audience by not asking, why did your heart stop?
Yeah, no, it's a good question. I get asked that a lot. I don't know, and nobody knows, which is, in talking to other survivors, young survivors, actually not uncommon for people not to have a great answer. Structurally,
the best term in medicine, idiopathic.
Yeah, that's right. Yeah, we love that, right? And so I don't know. I had all the testing in the world. I had genetic testing that didn't show anything. Obviously, my kids were tested, and my parents had genetic testing too. Like, do they have something that could have been passed on to me? Everything looks okay. So, not sure. And that's something I've had to grapple with, right? Fortunately, I have a defibrillator. So
you have a backup plan.
I got a backup plan just in case. It's the battery is about halfway out at this point. So looking forward to 5 years from now, going back in and getting a replacement. But, it is what it is.
Does that make it more or less difficult? Because I could see people handling it in different scenarios where they say, look, I have nothing wrong with me, so this shouldn't recur again.
Right.
On the flip side, I can see someone saying, if we don't know, anyone could just have this happen.
I think it's for me personally, I think it's better that, because having gone through, my medical training, med school, everything, the body does weird things. There's so much that we don't, and I think a lot of people don't realize that. There's just so much we just can't explain. We want to, we just don't know. And I recognize that. And I think, and going back to your earlier question about, does being a physician, help with something like this? I think this is one area where it might help, because I know how rare something like this is. I know what this defibrillator is going to do if it happens again, but we have no reason to think it will happen again. And so for me personally, I think I'm better off just knowing that my heart just kind of had a hiccup one day, and maybe I had a PVC at the wrong time and just went into VFib. I'm not sure.
Has it changed how you live your life?
Yeah, I'm like, one thing, I don't want any arguments anymore with my wife. So that's what happens whenever she saves your life, kind of thing. Yeah.
It's like a
pocket,
that's a card.
It's a card you have that's and I'm fine with that. I'll accept that. But it has changed. It has changed how I think about the future. I'm a little bit more easygoing when it comes to spending money, just doing fun things. Not worrying so much about some of the like daily little things that you worry about whenever you're trying to build your life and build up your reputation, your career and everything. And just, it sounds cliche, just living a little bit more and more freely. And it's also changed how I've interacted with my patients. Yeah.
How so?
I am much more open to talking about health insurance, healthcare system. We don't get a lot of that education, right? And so it can be a wake-up call when you get into practice and you're dealing with prior authorizations for the first time. And now I feel much, having gone through it and, advocated for change and all this stuff, like I feel much more confident and comfortable like discussing these things with the patient rather than saying, oh, just call the billing department. Like they'll talk with you about that. I take it upon myself to educate myself about how much things cost that I'm doing for these patients and being willing to discuss it, because it's just a big black box for people. And
being someone who has a comedic background, has dying changed your sense of humor?
Oh man. You know what? I don't know if it's changed what I've joked about. Because it wasn't until I went through all this that I started making a lot of content about the healthcare system. when I really started to go after the health insurance companies.
Okay.
You know, where I like put a fake poster on the wall that has like a health insurance company's mission statement that just says "Be evil."
Yeah.
Like before the cardiac, I don't know if I would have done that.
Yeah.
And so that firsthand experience really changed things. So it changed the content. I would say the way I do comedy and my style it probably hasn't changed, but certainly the content has.
Yeah. It's an interesting thought because of how perspective shifts so quickly, and then how long lasting that perspective shift can last. And with us being in healthcare, it's usually not our time practicing healthcare that shifts the perspective. It's our own life experiences that probably, at least in my experience, has shifted it the most. I had a shitty situation with my mom happen when I was in medical school, watching my dad go through medical education, more so than I reflect on what my day-to-day is like in the office. Oh yeah. Is that the same for you?
I mean, it's personal, right? And that's going to, when things affect the people you love and care about, like that, what is more impactful than that? Yeah. Right. And so I totally agree with you.
Yeah. So in working with the people who helped you get through all of this, who stands out? What person in this journey, besides obviously close family members, meaning more so in the healthcare system, that was like, wow, I didn't expect this person to show up as strongly as they did?
The first person that came to mind was my residency program director.
Really?
And it wasn't the cardiac arrest, it was the cancer diagnosis. So when I was a senior resident, I had my second bout of testicular cancer. So I already had lost one testicle. All right, now I get to lose the other one.
Yeah.
And all the questions that came up with that. And my residency program director could tell, like the second time around, it was a struggle because it's like, cancer again 4 years later, like what is happening, what's going on with me? And what he did is he gave me the space. He just said, take the time you need. And he also slipped me a $20 bill to let me hire a babysitter. I could probably get in trouble for that, but I don't know, it's like 10 years ago now. He handed me some money. He's like, get a babysitter, you and your wife, like go out for dinner, just the two of you. Okay. He's a great guy, I love it.
Is he older? This reminds me of a grandma giving you $1.
It was a little bit like that. Yeah. A little bit like that. It's like, so he's definitely he's like in his 60s now, but it was just so thoughtful. It's like he's thinking about like
the human side
of things, not just who's going to cover me in clinic,
right,
or who's going to staff,
which would have been easy to do so.
Right. Yeah. And I think it's really, and now I tell students that, and, pre-meds. And when I talk to them, I'm like, you want to go somewhere where people can react to major events in your life in that way, because in your 20s and 30s, that's when life starts happening, right? Family members get sick.
Yeah.
Accidents happen. You might have loss. You might get a divorce. You might, have, a baby, complications, whatever it might be. You want to be somewhere. You want to surround yourself with people who will understand what that's like on a human level.
Yeah.
And just be a real person who cares. And so that meant a lot to me.
Yeah. There's a statement that rings true that I've repeated a couple of times from a TV show writer we were working with, where he says, in any given moment, most people are not sick. So they kind of write off all these concerns people have who are sick, or that the healthcare system's flawed. But it's guaranteed that everyone will get sick.
Oh yeah.
Or will need the healthcare system.
I mean,
and that's when everyone's like, oh, it's too late now.
Right.
I needed to think about it back then.
Right. Like when I was 20, when you're 25, you've never had any health issues, you feel invincible.
Yeah.
Like nothing's going to hurt you. And then all of a sudden your testicle starts to grow another testicle. And it's like, oh, wait, this isn't supposed to happen.
Right.
You're a cancer patient.
Is that what happened in your case?
Yeah. It's just, a little self-exam one day. It's like, oh, I don't think this is, I'm not,
you're like, it's not supposed to mitose on itself.
Yeah, I know. You're not supposed to have 3 of these things. Yeah. So, that's what.
Were you regularly doing exams? Is that how you caught it?
No, I'm just a man who is very familiar with
No, because we used to advocate for regular self-testicular exams, and then we kind of moved away from it now.
Because every time I would post on social media about doing a self-exam, I would hear from someone, well, the USPSTF, their recommendations. I was like, you're really going to tell like a 20-year-old not to be familiar with their testicles? Like, let's be honest here. What are we doing?
Yeah. Oh, that's funny. Well, that's interesting that you went back to the cancer diagnosis, because I thought, surely you would have come across someone in your path of near death that would have been a
and I did. It was like my partners. It's funny because it was not actually. Here's one. Is my ICU nurse. My ICU first
Where you
person.
wake up.
Yeah, first person I remember waking up. Because this was the height of COVID. So Kristen couldn't be in the room with me. They couldn't be in the hospital, basically. And first person I remember asking me questions, trying to get me to remember my life, facilitating FaceTime calls with Kristen. And also, he was the first person to ever ask Kristen how she was doing.
Wow.
The first person ever check in with her. So he means a lot to our family. Yeah.
Yeah. Wow. That's powerful.
Yeah.
And now this has emboldened you to come on the quest of fixing the healthcare system.
Doing what I can as an internet comedian ophthalmologist. Yeah.
How does one become a comedian ophthalmologist? Because usually people select ophthalmology because they're like, top of the class, I'm crushing it. I want a great lifestyle. I want to make $1 million.
I think you tell one joke publicly. That's it. That's all. That's what it takes. And then you're a comedian ophthalmologist.
But you're doing this at a scale that's really setting the new standard. Because when I was growing up, doctors in media, there was 2, 3, and the huge majority of them were not doing a great job in terms of putting out good information, let alone funny information. I don't know. Do you remember from your education a comedian physician or someone that told jokes who was a doctor?
Not
like now we have Ken Jeong.
Not really. Yeah, we have him now. But even Ken Jeong, he left practice.
Right.
So the idea of
Robin Williams, Patch Adams situation.
That's pretty close. The idea of someone who's like a practicing physician, like being funny online. When I first started Glaucomflecken, because I have a stand-up comedy background. So I was in high school, college, it was amateur stuff. So I was never like seriously pursuing as a career. I went the much easier route of becoming a doctor. And
which I laugh, but that could be true in some ways. In some sick ways, that could be
I tell
true.
it as a joke, but honestly, seeing how hard comedians work, like that's not. So, there's always been this professionalism issue with which I think is why a lot of the doctors in media just kind of boring. Right? Yeah. Just didn't
robotic.
Yeah, exactly. Because that's what they were taught to be to the public. Sure. Like you are, that you're put on this pedestal of this pillar of the community and respected. And the only way to stay that way, to stay respected, is you can't tell jokes. You can't show emotion. You can't, be yourself. And so in doing comedy, as I was a resident when I first started doing this, I was anonymous at first because I was afraid how it would be taken. And
what was your stage name?
So I didn't, once I got into med school, I had moved away from like stand-up comedy. And so when I did the occasional stand-up comedy as a resident, which was like in rural Vermont. So it's like, maybe like 3 or 4 people would show up. It wasn't much. I was at Dartmouth, pretty isolated area. I was just myself. Like I was not Glaucomflecken. It wasn't until social media I started doing,
Which, by the way, can you explain why Glaucomflecken?
Why? Yeah. Why didn't choose an easier name to say?
Yeah.
Well, because I was a second year resident and I was like, I need something this is going to be a comedy, medical comedy. I knew it was going to be medical comedy. And so I was my mind was 100% ophthalmology at that point. So like, what's the funniest word in ophthalmology? So Glaucomflecken, it was either that or Dr. Pseudophacodonesis. And that was a bit too much.
That's hard to say. Both are hard to say.
Yeah. So Glaucomflecken is a real thing though.
Yeah. Tell me what that is.
When someone has angle closure glaucoma, eye pressure skyrockets and things inside the eye for lack of a better way to describe, or easier way to describe it, just kind of die off. And so you get these grayish white plaques and flecks on the lens, on the surface of the lens that accumulate from the denatured lens protein that are called Glaucomflecken.
Who named this?
It's hilarious, isn't it?
Wait, is this a person's name?
Fortunately, no.
Oh, okay.
Because otherwise Dr. Glock, the real Dr. Glaucomflecken
would be quite mad
would
at
have been
you.
very upset with me, because now when you Google Glaucomflecken, guess what comes up?
Not the scientific discovery.
No, not at all.
Back to the interview in just a second, but I wanted to tell you about Professionals Media Academy. If you're a working professional who's interested in building a career on social media, just like me or Dr. Flannery, you might be interested in signing up for my Professionals Media Academy. I get asked all the time for tips from med students and other doctors on how they can build an audience online. I wound up answering the question so many times that I decided to put together a comprehensive course that can teach you everything I know. Believe me, I learned a lot of lessons about social media the hard way, and this course allows you to skip all that pain and start on third base. The course not only teaches tips and tricks for establishing your social media presence, but also advice on how to get an agent, pitch yourself to television programs and press outlets, and even hire staff. It's not just for doctors either, but anyone who considers themselves an expert in their field and wants to turn their knowledge into a media career. Several times a year, I even jump in and do a live stream exclusively for students where they can ask me questions all about their content and businesses. This is the program I wish existed when I was getting started. Click the link in the description to learn more, and I'll see you in the class. So it must have been just like a German word.
Yeah, just a German word.
Yeah,
and
for flex.
It's kind of funny.
You know, naming stuff in medical lingo is so strange, because sometimes it's like, oh, Latin, it came from a historic thing. But then they go, oh, no, this is spaghetti and meatballs.
Yeah.
And I'm like, what is the guy, Hungary? Like,
well, how great would it have been to be like a medical professional in like the 1700s?
Oh, yeah.
You get to name everything
do whatever
after
you
yourself.
want. Yeah.
Yeah, like
and there are no rules.
The ligament of Mike. You know, I don't know. Like, you know,
where would that ligament live?
I don't know, somewhere near the spleen. I don't know.
Useless. You just go.
Well, you know, that's typically kind of the way it worked with these naming conventions.
You know who would crush in that era?
What's that?
RFK.
Oh, yeah. Yeah.
I mean, no one to fact check you, and you could just walk around saying, this is the ligament of Robert.
Oh, he would have had 40 humors by now.
We would be draining all of them.
That's right.
Oh my God. And we laugh about it, probably as a way of coping.
Well, I mean, yeah, that's what we do.
Because that's all we have at this point.
That's why I started doing comedy in the first place.
Was it a coping thing for you?
Yeah, it was, because it was, you know, I had gotten away from stand-up, and then I had the cancer diagnosis, and I was a cancer patient for the first time, which fortunately, you know, I just had to have an orchiectomy. So I had surgery. That's all the only treatment I had to have. But it just really, because I was, again, perfectly healthy to cancer. It was like just psychologically, it was a big deal. And I had to deal with that. Really, the only way that I knew how was by telling jokes. Something that, you know, with the comedy background, always been a bit of a class clown. I don't know if that surprises anybody. And so that's when I started doing medical comedy for the first time. Yeah. And it was just, you know, when you're faced with something in life that's like beyond your control, like you get a cancer diagnosis or family member gets sick or whatever, like you feel like control of your own life is taken away from you. And then what comedy does, at least for me, is it just helps me feel like I'm back in control. Like I can take that thing, that awful thing, whatever it is, and I make it mine again, add jokes to it, present it as something completely different to others, and we share a laugh about it.
Right.
It's so powerful to be able to do that, which is why so many people in the medical field have a wonderful sense of humor, because you kind of have to.
Yeah.
Right?
Yeah, it creates order amongst chaos and compassion in a way where it doesn't feel like it's pity.
Right.
It's like a pleasant compassion because you're all laughing together and enjoying the moment.
Right.
What was the first time that someone in your medical sphere, perhaps someone who's an attending, a preceptor, got wind of your comedy? What was that interaction like?
It was my residency program director.
Oh.
Because he's a very funny guy. And I felt comfortable like showing him, you know, some of the things I was saying. And I felt comfortable doing that. I wouldn't have felt comfortable with some of the people higher up, you know, who may have taken issue with some of the things I was saying, but I felt comfortable in that relationship. and he was very supportive. You know, he loved it. You know, he'd just come up to me and like, oh, I saw your tweet. You know, it's really good. You know,
if there was, I mean, he seems like a really reasonable person, but if they were like, shut it down, what would your?
Yeah,
you would have shut it down.
Oh yeah, I would have. And fortunately, he didn't.
Yeah.
You know, because I wasn't taking too many big swings. But I've said some things in the early days. I had to learn how to be
Find
a
the line,
comedian
right? Yeah.
as a physician. That's not exactly something you're just kind of born knowing where the lines are.
But it's so important, not just from the coping side of things. I say this at conferences, and perhaps it's cheesy, but I always ask a room full of young students usually, and I say, who do you think benefits the most from a laugh? What patient population loves to laugh? And they all raise their hand and they say pediatrician, because kids love to laugh.
Yeah.
And I'm like, no. All patients love to laugh, not just pediatrics. And the people who are most sick sometimes haven't had the laugh in the longest.
Absolutely.
So it's important, but then it's also so dicey because, man, if you cross the line, it can get you in trouble.
That's why, you know, people always ask me, you know, what do you do with your patients? Like, people like, can you give me tips on how to be funny with patients, like in the exam room? And I always make it very clear, I am not Dr. Glaucomflecken in clinic.
Right. Because,
you know, we don't have that much time
right.
to spend with patients. But I will say, if you can make a patient laugh, if you spend 10 seconds with that patient, if you share a laugh with someone, that is the easiest way to build long-lasting rapport with somebody.
Right.
Is that the emotion, what it does in your brain, the endorphins of just having a genuine laugh. But I'm not like in there, like, you know, like roasting
practicing lines.
I'm not roasting United Healthcare like in the lane.
You're not doing crowd work.
No, that's right. Because like we're there to do a job, but I've got little things I say. It's all dad humor because to your point,
puns.
Yeah, you got to keep it very generic. You don't know, you might, but if it's a new patient, you don't know anything about this person's values, how they were brought up, where they are politically. And so you got to keep it very, very basic, and that's fine. And it just decreases the tension in the room, and you got that patient for life if you want.
You know, it's something I get worried about when I do a presentation on what my journey has been like in social media. Some senior clinicians, C-suite executives are like, well, we don't want all these doctors making content. And while on one hand, I'm like, no, we do because we need to fight back.
Yeah.
But on the other side, I'm like, oh man, if everyone's making content, like there's bound to be a disaster, and like one disaster might be worse than 100 successes. So how do we balance that? How do you balance that?
Well, so this is a great point, because the influence of social media, it has grown so rapidly, especially in the medical field, that I don't think we've caught up in how we just navigate that from an educational standpoint, how we think about physicians as content creators, because as you said, it is so important. People get their information from social media much more than they get it from actually seeing a physician in person. Yeah, things like vaccines, that's always a better conversation to have with someone face to face. You can actually talk with somebody about it. What are their concerns and all that? But that's not feasible, for everybody. And so,
because you might not get that person,
right? You might not
even
get that opportunity, and so we have to do something. Otherwise, the chiropractors will take over.
Mm-hmm. What happens if they do?
We all have vertebral artery dissections, Mike.
All of us.
Yes, we're all of us. And then my clinic's going to be overrun by homonymous hemianopia, and it's going to be a big mess.
Oh my God.
So, but seriously, it's I think we're catching up on. I don't want to sound like old guard, new guard, but basically, that thinking of social media is not professional. You can't show yourself. You can't express yourself on social media as a physician. It's not, not okay. That thinking is going away slowly. And I think it's partly because we have people who have grown up in social media,
right,
who are now ascending to leadership positions and understand the importance of it. And now I think that ethics of social media is the next. We probably should already be having that conversation. We are having that conversation, but it's becoming a more important conversation of where are the lines?
Because I don't think students these days, even while they're thinking about it, they don't have good guidance of what does it mean to have a social media? Like the fact that we're answering in comment sections for Ivy League institution students of what they should be doing as social media or even practicing physicians. Right. You should not be getting advice on a YouTube comment section about your practice.
Right.
There should be some guidelines that are reasonable.
It's no longer okay to just day one of orientation be like, do not have a social media platform.
Because when I was coming in, the whole thing was like delete it during your interviews.
Yeah.
Right?
Or go private or exactly. Like you do not let anybody know where you are on social media.
Do you think program directors and school admission counselors are still checking people's socials? You think
Oh,
they are.
Okay. Oh, absolutely. I mean, yeah. I mean,
maybe what they're looking for has changed.
I think, and I can't speak to what they're looking for because I'm not on those committees. Yeah. I know some people on those committees, but I do think they're looking for, just professionalism. And the question is, what does that mean? Yeah, right. That's the question. What is
like the worst, most
what does professionalism mean? Are you spreading misinformation? Are you or are you making fun of the wrong thing? Are you making fun of patients? And so I think that's probably what they're looking for. I think the problem is everyone's got a different definition of professionalism.
Right. Especially the people who are usually in charge are usually older and don't have experience to know even what to look for when it comes to professionalism online.
Right.
Because I could easily see a provider looking at my content who's 60, late 60s, early 70s and being like, this is so unprofessional. And then on the flip side, I could see someone in that same age demo, just because they've been accustomed to seeing my content, being like, this is what we need more of this. And it's so strange to think how two people in the same position can look at it and have 180 approaches to it.
Yeah. And we need to, and I don't know if there's a right answer, right? I know what we can have guidelines, right? We can have guardrails for like what we feel like is an okay thing to talk about and to do on social media as a physician. I think it has to still stay somewhat general though, because you don't want to step on people's expression of who they are and what they like to do. But there are some basic things we can do. Yeah, we can not make fun of patients. That's something that I see a lot on social media still. And as a self-described internet comedian, ophthalmology person, it's a job title I've given myself. I think I'm the only one. Again, I only have to tell one joke, folks. Like just one joke, and then you qualify. We're a small club. So my mind's always in that space, right. And the algorithm feeds me. Anybody who's starting doing medical comedy, and some people do it really well and respectfully. Some people don't, and so a very basic thing is just thinking about the quote unquote hierarchy of the medical field. As physicians, like we cannot put out anything on social media that can be even perceived as making fun of a patient. Even if you personally don't feel like it's an okay thing to say, all right, that may or may not be true, but it's how it will be taken by actual patients. And I say this as someone who's made these mistakes. Like I said, it was a learning process where the lines are. I have been frustrated by patients in the past. I have said things I shouldn't have said, and I've deleted things, and I have apologized because I knew that was the right thing to do because I listened to those concerns. And so there has to be a certain level of humility when it comes to being a content creator, because you're not going to have the perspective of someone who has a chronic illness, who's who's seen a dozen different doctors, trying to figure out what's going on. Everybody's got a different perspective on the healthcare system. You're not going to know what that is. You're not going to come from that place. And so you got to listen but that's one basic line that I follow. And that's why you see in my content, no patient characters at all. I keep it all, punching.
But even with doctors,
sideways.
You've gotten some questionable critique on. I remember you did a skit about an overworked family medicine doctor, and some angry internet people came at you with pitchforks. And I remember writing like, I'm a family medicine doctor. I know how shitty it is. Yeah. And I think this is totally appropriate and a valid way to, especially knowing who you are, because you weren't like a new person on the internet. So how do you deal with someone perhaps seeing the negative side of what you're doing?
So that is, if there's one specialty I've had some pushback from.
Is it family medicine?
It's family medicine. Okay. Yeah. And I get it. Okay. I understand, because the character I have is overworked. It's underappreciated. And it can sting to have someone who is not a family medicine doctor kind of pointing that out. Now, I think it's in a sympathetic way, right? And so I stand by the characterization, but I do understand why someone would prickle a little bit at that characterization. And that speaks to this hierarchy even within the healthcare, within physician specialties. I can make fun of orthopedic surgeons and neurosurgeons all day because they're doing well. They're doing well, right? Making good money. Yeah. They, surgeons are, people have this idea of like, oh, surgeon, that's the top of the medical field.
I think RFK even trusts them.
Yeah. Right.
I recently went for surgery.
Like, what better thing could you be than a surgeon kind of thing? So it's like that respect, the societal respect is there that has been kind of eaten away by policy, by government, of people that do primary care, pediatricians, family medicine doctors. And so, it can feel, a little bit uncomfortable to like see someone like me, making fun of that. But what I'm very careful to do is not undermine their intelligence and the importance of what they do. So in those videos with family medicine and with all the specialties, even ortho, I try not to show ortho as this like idiot surgeon, because honestly, they're smarter than all of us probably.
Sure.
By putting in some like actual medical knowledge. And let me tell you, as an ophthalmologist, really hard to learn actual like orthopedic surgeon knowledge where I could pass as an orthopedic surgeon. I'm like doing research.
I mean, at the end of the day, all specialties are hard for one reason or another.
Right. They're all, exactly.
And if one person spent enough time in each one, they could probably learn it.
Right.
But we don't, because we have capacities as humans.
Right. And so even this whole idea of like not punching down.
Yeah.
I think when I'm talking about physician specialties, I feel like I'm kind of more punching across, like I'm punching you, which I wouldn't want to do because you're a much better puncher than me. And so I think that's still okay. As long as people don't feel like they're being taken advantage of, and that you're belittling what they do as a physician. And the most important thing with satire is there has to be some truth to it. And so, yeah, I might make fun of your specialty, but if you can look at that video and be like, okay, that's true. That's actually, yeah, that's kind of how it is. Then you're good. Like it's okay to do that. So
I think what you're saying is very valuable in the sense of, I think about it like a medical treatment, right? You wouldn't give someone antibiotics just because, right? You would only give it if the risk benefit analysis was there and it was in your patient's favor. And with any treatment, there is absolute and relative contraindication. So I think of social media and posting on social media with those same rules in mind. There are absolute contraindications. Don't make fun of patients. Absolute contraindication. Don't give individual health advice because they're not your patient.
Right.
You didn't examine them certainly through the comment section.
No
you didn't
HIPAA
get all
violations
the
too.
like those
that.
basics.
Yeah.
And then there's relative ones that are a little bit more vague and require nuance and are individually decided upon which is hard when there's a lot of individuals
It's really
deciding
hard.
it.
That's where that line is, right?
Yeah. And that's where we have to be okay with some learning growing pains.
Yeah, we do.
So it's tough because I see that as someone who's also made content for a while. It's very easy to do something wrong with good intentions.
Correct.
And a lot of times intentions to the World Wide Web that's so huge aren't seen and are not evaluated with intentions in mind, which in some cases maybe doesn't matter. But
Maybe it does.
that's why the takeaway is really complicated. And it brings me to this conversation of this medical student, Nick Baumel, I think his name is. He got in trouble recently for he does skit type videos, and he's done a couple that have gotten people very angry, making content in the OBGYN space, critical of the field, critical of women, perhaps in poor taste. And initially, when I saw this come across my feed and I was watching this happen, my first thought, and I'm curious if you had this thought as well, is this person even in the medical sphere? Because I don't know who this person is.
You always do have to question that because
there are people making skits in scrubs all day long.
Yes, that's true.
I actually thought were medical professionals and they weren't.
Right.
So I've had to check myself on that before I got really angry. So I checked that and I realized this was in fact someone who's a student. And then second, I started thinking, okay, let me absorb this and let's see how this lands. First, I thought about this principle of don't make fun of patients. And it actually brought me to the time when, I don't know if you remember this, when TikTok was kind of in its infancy, there was a CMA, I believe, that did a skit to a sound on TikTok making fun of a patient's breathing. And it went crazy viral. I don't know if you remember.
I don't remember this one.
And she was kind of like, and making fun of the patient faking it or something. And we covered it. And the whole premise was basically don't make fun of patients, et cetera. And it brought me back to that. I'm like, well, this person's clearly doing something at the harm of patients. And then I started thinking, okay, they're trying to be funny. They're trying to be a comedian. Maybe we need to be okay with towing this line. And I started almost making excuses for why this was okay, putting myself in the content creator shoes.
Yeah.
And then I started zooming out. And I said, let's think about this from every other possible perspective, which I like to do as much as possible. Here I'm thinking, okay, if I'm a patient and I'm seeing this, how does this make me feel? And is it unreasonable to think that this person has really bad intentions? And I think the answer to that is it's not unreasonable. It's a fair take to see this and be disgusted by it, grossed out by it, to think that this person doesn't have your best interest in mind. And then the final takeaway, why I think ultimately it is bad content, bad video, not right for a medical professional to do, is that if this person ran a pizzeria and made a skit that was seen as bad by some group of people, those people would not visit that pizzeria. And it's not like this person was truly harmful, crossed some sort of comedic line. It would hurt their business. But this is a medical professional where you might end up in their care, in the emergency room, because the health care system sucks. And now you have no choice but to get care from a person who you believe is actually harmful to you. And I feel like that's the line that no longer made that content okay for me. And I'm curious if that lands the same for you or similarly.
Yeah, no, it does. It does. I saw one of the videos. I understand there were more.
Yeah, there was a few.
Yeah, I saw one of them, and immediately it was like, no, like this is not okay. And it turns out, like shortly after that, it was deleted. Like the whole account was removed. It was misogynistic. It was doing everything that we've been talking about, you know, of punching down, and you know, I do want to acknowledge that we're two men talking about this, right? And so we can't put ourselves into every space, you know, especially with this type of content. You know, we're not women, and all the issues of women not being listened to, and you know, being taken advantage of, and you know, suffering harms by the medical system are all very valid. And so I saw that content, and yeah, misogynistic, not appropriate, definitely crossed the line of professionalism. And you know, there is this tendency to, you know, historically, for us to like weaponize professionalism against physicians who are trying to make content or be funny or give information or whatever. And that's because we do have a higher standard of professionalism we have to maintain on social media. We are not your run-of-the-mill stand-up comedian, who can say whatever they want because that is their job. No, our job is to take care of patients.
Yeah.
And so, we have to find what that line is and not cross it. And that easily crossed the line and was, unprofessional.
Yeah, I think that what you're pointing out there is so valid. From a stand-up comedian's perspective, if that's your primary job, it's more important to try and go past the line to know where the line is. But if your primary job is being a health provider or a physician or a nurse and people are under your care, now it's more important to never go above the line, even if it means being less funny and less optimal on social media.
Exactly.
And that's the lesson that's not taught to students.
Right.
Like when I say to folks, they say, what's a good way to start on social media? I say, experiment, try things that you're passionate about. It's never go extreme as possible because ultimately that's not the message we want to send. It's the opposite. Be as conservative as possible while injecting a little bit of your human self.
Absolutely. Because the dopamine's real.
Yeah.
When you have a video that hits. And so there is this feeling that you get when you have a video that everyone's laughing at, like you're getting all that positive reinforcement, and then you just want to keep going. Well, then maybe you push a little further, and that gets even bigger. And so you can see how someone can go down a path that leads to crossing this professionalism line.
It's like a drug.
It is, and so, and these are the things we need to be. Letting these students know, whenever they're pre-meds and med students who are starting social media platforms, because we need doctors on social media, but we also need to not do anything that will undermine the public's trust in us.
Right.
That is first and foremost. Second most important thing, like don't get fired, like don't lose your job because we need you to be practicing patients.
That's the first.
We need doctors, right?
Yeah.
And so just, we have to. But we have to be thinking in terms of like, if I post this, and I still do this to this day, I think, okay, how can this be interpreted from different viewpoints? I do the best I can. Like, what would a patient think about this? What would a health insurance executive think about this? I'm okay making them upset. That's punching up. But thinking about it from a different perspective outside of yourself, I think is helpful. Because then you could think, oh, I can see how this could be seen by a patient as maybe they wouldn't want me as their doctor, or they might be hurt by this. And then you don't post it, or you change it, or and so we need internal guardrails with ourselves, but we also need to be having these conversations that we're having with people when they start medicine.
Yeah, I think that this idea of trying to be perfect on social media is not real, but also this current Nick situation that we're discussing right now really highlights how extreme social media has gotten. And the reason I think that is because there's so many people in the comments when the initial videos came out and doctors were posting that they were upset, that this shouldn't be professional, there should be some action taken. There were people in the comments saying the opposite, defending him, saying like, no, this is no big deal. I think it's because they've seen such terrible stuff online from famous creators that are not perhaps in the healthcare space, that they don't realize that in the healthcare space, we need to be even more conservative than the traditional person in content. And they don't understand why, because they've never been put under not the microscope, but under the pressure of having to take care of another human. Yeah. Or perhaps they haven't been taken care of by a human who comes in acting unprofessionally or rude. And the second that they will, I think they'll recognize why that content is not right.
Yeah. And honestly, I think if you ask 99% of medical professionals, is this okay to post? Like, I think we'd all, I hope that the vast majority of us agree, like
Right.
this is not something you do.
And that's where I think the tough line is, because if we agree it's bad, what should happen to someone at this point in their career? And there's been both good and bad statements by medical boards, not necessarily for this case, but for doctors getting in trouble for misprescribing medications, opioid scams, hurting patients, not losing their ability to practice medicine, or perhaps just being temporarily suspended or put on some observation, where it's like, what is the line if you've set all that precedent for people who have truly harmed patients for someone making a mistake?
Yeah. Yeah.
And that's tough. That's where consensus is important from an unbiased party to come in and evaluate the situation from a 360 approach, because we don't know what the whole situation is.
Yeah. And you could argue that these videos like did cause harm.
Of course.
Right. Like that, like absolutely. And so, but this is where there can be like a little bit of nuance to this conversation, which is not a place that you can often find nuance on, in the comment section on social media. Right. And I could honestly see great arguments for like posting content like this and you disqualifying yourself from ever being a physician, to also like having some corrective action to prove like you can professionally see half the world's population.
Right.
And so what we saw on social media was
people taking one side,
people taking
other,
one extreme side to the other, and
which is understandable. But at the
Right.
same time, we don't know. Has this person made content like this before that was deleted? Was there inappropriate statements made to other classmates? Because how easy is it to make a judgment then? Oh, this is a repetitive situation, making inappropriate statements to classmates.
Yeah, we're not in the med school. Yeah. We don't know what the situation was. None of us on the internet, us included, can really say like what should happen here.
Right. And it's not our place.
It's not our place. Yeah. We can talk about why this never should have been posted, the harm that it causes people.
For sure.
That is really what we need to be focusing on. And the people in charge of letting the student graduate or match or whatever, like it'll be up to them based on the whole picture to decide, what is appropriate here. And
I give credit to Mayo Clinic. Like they posted right away a response that they're investigating and that this is going to be some action taken. And I think that's the most fair thing that you can do in a scenario. And who knows how it plays out.
Like if someone violated a code of conduct, which I'm sure this did, is there grounds for expulsion? Yeah. How do you argue against that?
Yeah.
Right. And so, I agree with you. I saw the response from Mayo, and they're gonna, do what they need to do to, in this situation.
It's a very complicated world because, again, as I'm telling physicians, hey, you should show your humanity. Don't be afraid to show yourself. Some physicians, maybe when they show themselves, they show too much. Yeah. And besides be normal, which I don't even know what that means anymore, I don't have good advice.
Well, and that's why I think we really it needs to be,
because the head of health and human services right now does not follow any reasonable code of conduct or scientific integrity.
Exactly.
In fact,
professionalism standards.
Was a student in that school, he would get expelled week 1, and yet he's in charge of all of us.
So that's why we need to have, and there needs to be like actually explicit curriculum around this subject. It cannot be like day 1 of orientation, be like, don't make fun of patients. Like it's great. I've been saying that.
Right.
It's important. There needs to be more. We need to show examples. We need to show, we need to actually spell this out for people. We
just didn't have it many, I guess.
We don't, but now unfortunately, we're now in a place where we've seen people post things over the years that have gotten them into trouble and have been deemed unprofessional. And so all of this needs to be made available to people early in their career. Be like, because we can't, although we don't know, there's some like where the line is, it can be subject to interpretation. There is a line, and we do know when it's crossed fully, and so that at the very least, that's where we need to kind of inform people.
I worry about it. I'm curious if you worry about the future med students, not just with social media, but them seeing RFK Jr. at the head of Secretary of Health and Human Services, Dr. Oz at CMS, doctors that are selling snake oil, miracle cure-all products, what have you, like the whole supplement scam. They're seeing all these people enrich themselves and get extremely successful.
Yeah.
Will this play out in the same way that we've seen the hierarchy of specialties form in medicine, where it's not a surprise that the top picked specialties are the highest paying. So now are the bright students going to go into the field of snake oil as the new specialty?
That's such a bleak future.
I'm worried about it. I'm worried. I mean, you have AI at your disposal. You can weaponize AI in any way you wish.
Yeah.
You can literally get AI to be your lawyer for you to be evil. You can say I know what science says, but make this argument still hold strong to the average. You can literally feed it that way.
Yeah. Yeah. I fundamentally, even to this day, when you see med students match on match day, which just happened recently, right? It's so much fun to see the reactions, and then you go, to a commencement and you see the joy, the energy of these people who are starting out on their careers. I still think in every single med student, their motivation, their drive, is for the right reasons.
I'm going to push back. Do you think every student?
I think so.
No, come on.
No, maybe I'm just being optimistic.
Rose-colored glasses a bit.
Okay, maybe a little bit.
And I want to defend. I want to be
maybe a little bit.
I want to be on your team.
You honestly, you think that there are incoming med students? They're like, the minute I get a request to hawk a supplement, I'm going to.
They don't think that far, but
you think they're.
I mean, there's the numbers.
Yeah. I mean, maybe
sample sizes. Outliers.
I think
outliers exist in data sets. That's how I think.
True. Okay. So it's not 100%, but with social media influence, that's when all that stuff starts coming, right? And so that's why early on we need to get a hold of this, and talk about these things. It's not being talked about, and all of a sudden you get 6,000 followers on TikTok, and you get inundated with, we'll pay you $10,000 to sell, extends, whatever the hell it is, right? And you're a poor med student who's going into $300,000. Who among us, right? And so these companies, this way of thinking it's preying on the insecurities, the financial insecurity, the fear of, is AI going to take over my job? I better start making money now. I think it's all external. It's all external pressure. I am probably just me being optimistic. I think the vast majority of us that go into medicine at our core don't want that. We want to do the best we can for patients in our community or whatever specialty you're going into. And then it's this external pressure from the education system, the amount of debt we're in, our inability to feel like we have agency in our jobs, the private equity, insurance, consolidation, all that stuff that's making it more difficult to just practice medicine and have the type of life that you wanted. Because we make good money. Because you go into medicine in part because it's safe, and you're going to have a good living and also be able to do this wonderful thing, helping people. I still think that's maybe not in some people, but in the vast majority of us, there's a nugget of that still there. And then it's all those external forces that just eat away at it.
Yeah. I could see people getting fed up. I could see it. I see who's getting successful, even in the social media sphere. The people who have the best financial outcomes are often the people who have pretty crappy intentions. Yeah. And that works so well for them, and they then just fully lean into it and say, oh, well, it pays to be hated. Or you have the Gary Breckers of the world who's not even a physician, going out and giving health advice and people weaponizing it with private equity and finding ways to make this person the face of their new industry. And then they weaponize the fact that we work with pharma companies when it's totally reasonable to work with pharma companies because of historic faults of the past where doctors would take kickbacks from opioid manufacturers or whatever it was. And they point at us, they say, you're the problem. Whereas like, no. The thing you were pointing out back then with the opioid crisis or these specific examples, those are the problem. We're happy to point those out. But you selling a red light bed for $60,000 is also the problem.
Yeah.
And how you get that to the general public is really tough because you need to get their attention first. And if you don't have their attention, you don't have anything.
Right. So misinformation sells. It views, it gets views, it gets the more outlandish you can be. Like I could get millions of views. I could just start sending my perineum and I could make a video go viral. Everyone would love to see my perineum. So, but the point is like you can gain a following so much faster, as you said, like to talk about these things and to make outlandish claims. Like in ophthalmology, I could put out a video where they started out saying glasses are making your vision worse. And people be like, what? I wear glasses. It makes my and then I could like sell whatever kind of glasses I want. I'd be like, no, these glasses, or do this, or get a blue light, whatever. And
who's there to check you?
Right.
No one.
No, a few people will show up in the comments, but in general, it's not going to deter me because I got the money for it. And so
what's the deterrent that we create for that?
That's the $1 million question, right?
Probably billion or trillion at this point, but yeah.
I mean, one way to do it would be just, shaming people, but that doesn't feel good either. I mean,
how effective is that when shaming them, you giving them attention and airtime, and now the algorithm shows it to more people.
Right.
So even if 5% of people only fall victim, the more people, that's a bigger number.
The platforms have to do it.
But they're not medical platforms.
And
they don't know what's
right?
real.
And why would they do that too? Because it's bringing in money. They're hurting their
science needs discourse. I mean, we need people to come in and have wild ideas. They just need to be tested.
Yeah, right.
Now we've reached the point.
Actual science, evidence-based medicine. It's hard to make it fun and engaging. It can be done.
Right.
We do it. Right. Lots of content creators do it. But it takes work and it takes thinking outside the box. How do we make research fun? How do we make it to where like accessible to the public? These are things we haven't thought about really in a long time. It's just, how many, when an article is posted in JAMA, is published in JAMA, like how many people outside of the medical field are going to see that?
Zero.
Right. Yeah. And so,
unless New York Post clips some absurd headline from it.
Right.
Which is not even accurate.
But the misinformation peddlers, like they're not publishing in JAMA.
Of course not.
They're just putting it out on their channel for millions of people to see and to accept as fact.
Well, do you think it's worse when a doctor spreads misinformation or when it's a non-medical person spreading misinformation?
Oh, it's so much worse when it's a doctor.
Why?
Because then you're weaponizing your credential you're trying to you're showing people, look, I can talk about this. I have these letters after my name. You can believe me, even though everything they're saying is nonsense. I think that although it's still harmful for people who are not medical professionals at all to be selling supplements, I feel like there's a limit to how much damage that can do, that whenever you add an MD to the end of the name, like it kind of takes the guardrails off of it and you look like you disagree with me.
No, I'm curious if you, how you've managed over these years in your social media success to not be lured into an avenue of pursuing a crappy product or a miracle cure-all product. Like what's giving you the right path?
I asked myself two questions. Is this product good for patients or good for medical professionals or both? And I have to convince myself using evidence, using all the tools that have been given to me by the healthcare education, by medical education, that is true. And if I do my due diligence, and that's what it takes. You have to, and these things that are not evidence-based, it's very easy, very obvious. Like any supplement, for the most part, is
you could convince yourself. Confirmation bias is strong.
Yeah, I guess you could.
You could say, "Oh, vitamin D is so important," and a lot of people are vitamin D deficient. So, like, what's the harm?
Yeah. That's a good point.
Because I've sat down with people I disagreed with, not just on this channel, but in real life. And I met with people who sell a lot of questionable products. And it starts with this, oh, well, I had a small group of patients who didn't want to buy products because they didn't trust them. And I said, you know what, let me go out and make a product that you could trust because it was just for them. And then like more people started just buying it. And then now that more people are buying it, I outsourced to an agency. Now the agency's kind of running with it. And before they know it, they're kind of in this thing. And not to make them sound innocent, but it kind of happens without this very clear line that you're crossing. There is no clear line. It's just at some point it's like, whoa, how did I get here?
I mean, I think if you're convincing yourself that something is good, then you're probably not following evidence, or maybe you just don't know how to interpret it, or you're cherry picking, stats and studies. And how do you stop that from happening? I mean, it's going to be hard because there's a lot of money.
Yeah.
That's going to draw people.
How do you handle conversations in real life? You do conferences, you meet people where you meet someone, they're either spreading misinformation or selling something questionable.
Yeah.
Are you friendly? Do you ask them about it? What's your approach usually?
Honestly, in the things that I do, I don't know if I come across a lot of those people. Yeah. Because I try to be very particular with where I go, like who I speak, like, I don't want to give attention to those types of situations. And so, and to the point where, like, if I'm speaking somewhere and I'm like, I ask them, like, do you have any sponsors? Like, let me see your sponsor list. I want to see like who's actually sponsoring this thing. And I won't go. The worst thing that's happened, I would say, is like I've given a talk where I'm very critical of like health insurance companies, as I typically am. And I'll have an Optum person come up afterwards and talk to me.
Like a C-suite exec?
Yeah.
Okay.
They're like, and there have been a couple times where, they want to take a photo with me, and I've obliged.
Because you're human.
Because I'm like, how do you deal with it? Like, no, because they're nice to me, but that doesn't mean I agree with what they have to say, right? You're just being.
Well, let's talk about what the health insurance companies are doing wrong these days. What's your biggest issue with the state of health insurance in our nation?
I mean, not great. Like, it's
understatement.
Yeah, it's it's understatement of the year. It's we need to like turn them back into health insurance companies at the very least. Right now they're so vertically integrated. They're owning PBMs, they own pharmacies, they own physicians. Optum's the largest employer of physicians in this country. And that's just driving up prices for everyone and costs. And so I come at it from my own personal story. After I had the cardiac arrest, one thing I didn't realize was just how many bills you get as a patient, like dozens of bills. And they're coming from
duplicates.
They're different places, like bills that you think you've paid already, but you're not sure. And then you get like an explanation of benefits from your insurance company that looks like a bill, even though in fine print it says this is not a bill. And it was like, I've got this stack of papers. And at first I was thinking like, why did I not opt for like paperless billing? But also it was overwhelming. And I'm a physician. Like, I know more about this, not everything. I know more about this than the average person. And it was still very confusing for me. And I got up all these bills, and this is basically the origin of like me even getting interested in this in the first place. And there was about $20,000 that my insurance company for this hospitalization wasn't covering. And I knew that wasn't right. And so, I did the most difficult thing any American can ever be asked to do. I called my insurance company. And turns out the ambulance took me to an in-network hospital, but the doctors that took care of me in the hospital were out of network.
Which is, of course, your fault.
Right. I didn't check before my cardiac arrest. Big mistake.
What the hell?
Toll-free number on the back of your insurance card, Mike. And so and so it was a 9-month battle, before they finally, actually here's what happened. It was obviously there's a surprise billing. And now this exact scenario wouldn't happen now because we have the No Surprises Act, which is not perfect, but it does help prevent stuff like this from happening. I called and called. I sent emails. I posted on social media, which is something I have the privilege of being able to do. Not everybody can do that. And finally, after about 9 months, I noticed that my balance was 0 on my hospital bills. It's like, they must have paid for it. But I wanted to be sure. I wanted the satisfaction of knowing, like, the insurance company actually paid this bill. And what happened was the insurance company just put pressure on the hospital to forgive the charges.
What?
Yeah. Yeah. So the hospital didn't even see any of that money, but they just forgave it. I guess they were tired of dealing with me. I don't know. And so it was this whole experience. I was like, okay, I got to start making like videos about this, making content. And so, everything from like, what is a deductible? What is a prior authorization? What is a PBM? That's something I didn't even know what a pharmacy benefit manager was when I started practicing. I never even heard the term, which is another problem. Like, we come out of medical training, we don't know any of this stuff, any of these things that are dictating medical care for our patients. I had to figure all that out and just started making these videos where I could try to explain it in terms not only I could understand, but also that just the average person.
Well, sometimes that's the best way to get information across. First, learning it and simplifying it for yourself, and then presenting that to the public.
Yeah, and the reaction I got, because I was just posting these things on my channels as just I was just frustrated. I was trying to same thing I've been doing all my life, just dealing with that through comedy. And but I did start to realize people are actually learning from this. And I realized that when it comes to advocacy and trying to change something, medical field or whatever it is, or medical, the healthcare system, I think we overlook the impact that just education can have on it. I don't know if I have the right answer. I have some ideas, breaking up this vertical integration that's happening, turning insurance companies back into insurance companies, so they don't own all of these different aspects of it. But how do we go about doing that? That's way above my pay grade. I don't know necessarily, but what I can do is show people what the problems are, because you can't advocate for change until you know what it is you're changing.
Right.
And people in the healthcare system know, but the vast majority of the public, they don't know.
And most, I would even venture to say, in the healthcare system don't know.
Right. Or at least know maybe on a surface level, but not some of the forces beneath the surface, because that's the whole point.
They make it so complicated.
They make it so complicated. It's shrouded in darkness, and the PBMs don't want people to know what a PBM does.
Tell people what a PBM does.
It's a middleman. That's what it is. Mm-hmm. They negotiate with pharmaceutical companies to dictate how expensive medications are, what medications can be on a pharmacy's formulary, and they're the go-between between the pharmacies and the pharmaceutical companies.
And the big problem is that they're now owned by one of those two entities.
Right. There's exactly. So now you got, the independent pharmacies are going away because you have Optum and Cigna and all these, and they're buying up all the pharmacies or pushing the independent pharmacies out of business. And they own the PBM. So they're deciding what goes on a formulary for the pharmacies that they own, all based on what kind of rebates they can get
from themselves,
legal kickbacks from themselves. So Anyway, this is
it started as a coupon company that became for profit. That's how I try and simplify it to myself. Because they promised us savings,
right?
And then they became $1 billion company on themselves. I'm like, wait,
right?
What? How does this work?
Exactly. And I, one thing I hear from people a lot is two things. One is like, we need universal health care. And I get that. And you know what? My goal, what I want to see happen is accessible, affordable healthcare for everybody. Like, who can go against that? Like, of course, that's what we want. But I think how we get there is where a lot of us will differ. And like, sure. People who say, look, we just need healthcare for all. Like, okay, we're not going to pass, maybe this is just being pessimistic. I don't think we're ever going to pass a piece of legislation that's going to achieve that goal in one fell swoop. And so it's going to be stepwise changes, something like the No Surprises Act, which takes this very big specific problem and tries to make it better. Then we take another big specific problem, we try to make that better. Elizabeth Warren and Josh Hawley have this bipartisan bill, the Break Up Big Medicine Act, which is trying to like break up these big conglomerates, break up the vertical integration. Does that give us universal health care? Well, no, but it's going to make something better for a lot of people.
Yeah.
That's kind of my approach to how I think that we can fix healthcare.
That we do need some sort of practical stepwise solution, because I think otherwise we're just waiting for it to break. And maybe when it breaks, we can rebuild it differently. But man, when it breaks, there's a lot of casualties here in the system.
Yeah.
Because I've heard people say like, oh, well, the pandemic nearly broke the system. If it only broke, we would have solved it. Do you know how many people would die if the healthcare system would break instantly on day one?
Yeah. Oh yeah.
It's just like from even a trauma perspective of accidents that happen on a given day, if they're not being cared for.
And so it just irritates me whenever I, advocate for a change and then someone's like, oh,
you're not doing enough.
Yeah. Why? What's wrong with healthcare for universal healthcare?
Whataboutism from a very popular stance.
This is why you stay out of the comments section.
I mean, we'll do a video on heart health. Everyone's like, "Are you kidding me? What about the kidney?" And I'm like, "Man, like I can only advocate for one cause in one video." Like the fact that we're doing one video should be okay, and we could talk about this.
Let's focus up, folks. Yeah. We can care about more than one thing.
No, but that happens a lot. I don't know if you get that. We're tackling one cause, and it's like, but what about this thing that you're not advocating for? Yeah. It's like, well, there's a lot of things to advocate for. Our system's really crappy right now,
and doing it through social media is great. Like it's amazing how far our messages can get, just because we have a big platform,
a soapbox,
or any kind of platform. And so another reason, talking about like, should physicians, with this whole Nick Baumel thing, has been a lot of people are like, is it even worth it being on social media? Well, I think it is. It has to be, because misinformation we've already talked about, but also our ability as healthcare professionals to know what those problems are that we're having. We know where the bottlenecks are. We know why we're running an hour late in clinic. And guess what? It's not because we don't want to see you on time, right?
It's not because we're filming skits in the back.
Right.
Which people assume, by the way.
I know. And you can understand, because,
of course,
because we're the face of healthcare. So, which is another reason why we need to be on social media talking about this stuff, because when something goes wrong in someone's personal healthcare situation, usually, especially if it's like a healthcare system type problem, health insurance, whatever, costs, usually it's the doctor that gets blamed, because like they're the ones.
Yeah, that's who
we're the ones they see, right?
You're the person.
And so you get that. Like, I understand why that happens. And so what we can do is like, no, actually, like, this is what a prior authorization is. This is how Optum is denying, using AI or algorithms to automatically deny claims, and we have to do, appeals and all these things to try to get your care covered. That's all that below the surface stuff that we need to get out to the public. That's being suppressed.
You know what's interesting? I had the former head of CMS, who's used to be Dr. Oz's position, and even she was honest about the fact that when she was getting care for her family, she was struggling with the same issues that she knows patients are going through, and she ran the system. So like if that's the level of complexity.
And that also shows that like it should be easy to try to make a fix.
If the Genius Bar can't run an iPad, we have a problem, folks.
But like nobody likes what we're seeing.
Yeah.
Nobody, like, the bipartisan, like everybody should be able to agree, like, we got to like make all this stuff better. This is not working.
Yeah.
There's a lot of powerful people though.
There's a lot of powerful people, a lot of capitalistic, powerful forces that don't want to be held in check, because I think the only way you have some form of healthy capitalism is with checks in place. Right. And right now these checks are not being, maybe they're not on paper, but even if they are, they're not enforced in a toothless administration. So I'm curious, this is shifting slightly. I did this debate against people who were anti-vaccine and people who are RFK Jr. or Maha supporters.
Well done, by the way.
Oh, thank you.
Like I don't know before you go on, like how you stayed so calm.
You would too.
Oh man, I don't know. Like I was trying to put myself in that situation. First of all, there's no way I could have done as good of a job as like you did. You did fantastic.
Thank you.
I was just thinking like how is this not like just a bloodbath of like everyone just like wanting to kill each other, like literally. So good job.
Thank you. That's sort of my question.
And why did you agree to do this in the first place?
I'm thinking if I should ask you the question first or tell you why I agreed to do it. Let me ask you the question first. Do you think we should be having these debates with people? Or, because I recently did a conversation with Dr. Paul Offit from Children's Hospital of Philadelphia, where he believes that you shouldn't debate those who are anti-vaccine. Where do you land on this?
I disagree with that. I think, and I mean, you could probably speak to this a little bit more, but I don't think things like the debate, the public debate you had, the produced,
Sure.
thing. Can I say surrounded? Can I like,
yeah.
All right. Yeah.
There's no legal
I don't know
ramification.
I don't know if you're, I don't want to like badmouth like that situation, but okay. Let me.
Please badmouth it.
Okay.
Badmouthing is where I get excited.
I don't think that format, like the surrounded format, where it's like heavily produced, edited, I don't think that's going to change minds.
Okay.
I firmly believe that.
Okay.
I don't think...
You mean the people in the room or people watching?
Both.
Both.
Because I honestly think the only way to change someone's mind about something as like vaccines, any big abortion, whatever it may be, hot button topic, it's sitting across from somebody, but not in kind of this heavily produced, like surrounded thing. It's in the exam room. It's going to be, now, unfortunately, that's one person at a time. So like doing mass
and
changing of minds.
That don't like you won't come in. So you won't be able to change.
Right. And so I think that's honestly, and from what I, talking to my fellow physicians, pediatricians I know, because I've asked them this, I've been curious, like, how do you do this? Because I've seen people like you on social media trying in this surrounded format, trying to do exactly that. And I've heard success stories from pediatricians, and it's like in an appointment, sitting across from a kid's parent and just talking like normal people, and giving your honest expertise and evaluation, and people have changed minds in that way.
Oh yeah.
And it happens. So I'm a bit skeptical that social media can actually do that versus just rile people up and get people kind of angry.
I see. The reason I bring it up is because there were people in the medical community that were upset that I did that they felt like this was platforming a negative message and doing it in a less than ideal format, that essentially we were platforming anti-vaxxers. That was the summary.
I wouldn't go that far. I honestly don't. I'm just saying that because I'm sitting across from you and I like you, and but I don't think that you did anything deleterious to the overall message of we should be vaccinating people. And that's partly because you came off very professional and calm. And that was in stark contrast to some of the anti-vaxxers that you were sitting across from, which is going back to how to present yourself on social media as a physician, right? You got to be calm. You got to be professional. And so I don't agree with that assessment.
And to go back, the reason why I volunteered for this was because I saw Charlie Kirk and Ben Shapiro do it the first 2 episodes, and they crushed. I think Charlie Kirk has like 50 million views on a 2-hour long plus video. Shapiro also something like 20 million. And I'm like, people love this debate style, argumentative thing, dunking on each other. Oh, it's good theater. People love this. It's like the new gladiator arena for people. They love to watch this, this car wreck, basically, like the rubbernecking of it all. And I said, what if I go in there and I volunteer and I let them throw whatever at me, and I just don't get mad, and I be empathetic like I am in the exam room, and I hear them out. And when they ask me a question, I answer it as honestly as I can. And when they ask me something I don't know, I say I don't know. And I just allow these 20 or so people to have a positive interaction with someone who they imagine has horns, because everyone in their life has told them they have horns, and the advocates have told them that they have horns. And I reached out to them and volunteered for this, and they said, we actually think it's a great idea. And they set it up. And when I got there, I was like, oh man, I think I shouldn't have done this. Because you walk into this cold room and you know it's going to be 3 hours and you don't know what's going to be said, and you want to represent medicine to the best of your ability, and you want to hope that your knowledge will not have a brain fart. But ultimately, my goal was to just walk away with those people not having a negative butting of heads interaction with someone, and not change all their minds, but perhaps allow them to leave and be like, why is that guy saying the vaccines are good? Because he didn't seem like a bad guy.
So I want to say that I think I said that you couldn't, sitting across from someone, that's the way to do it.
Yeah.
I think it's possible for those people in that room that you might have, sparked something to change, their way of thinking. I don't think that is possible to anybody watching that.
Interesting. Okay.
Because of that's not the purpose for the company that put on this event.
Well, they expected me fully to dunk on people.
Because they want the theater.
They wanted the viewership.
They want the views.
And I wanted to prove to them that you can go in and not dunk on people.
Oh, okay.
Be empathetic.
All right. Good. Yeah. Well, you definitely did that.
And we're the 3rd most watched episode of the series.
That's amazing.
So I wanted to have that as like a proof of concept. Like, you don't need to bring in provocateurs to have a good conversation that a lot of people want to watch.
Yeah, I think that's.
So I was hoping that could also serve as something for them.
Well, I think like I said, I think it was great. I would have loved, like, if we could have seen an unedited version of this.
I would say it's pretty much unedited. Like, they shortened it for time and they cut out some weird
Did you
scenarios.
have enough time with each person?
No, because that's limited by the people raising the and that's the format thing I didn't like.
And that
sucked.
That's where I think it breaks down in terms of the ability to actually change minds. If you're a viewer actually watching one of these conversations to its conclusion, I think now we're talking about a much different impact.
Yeah.
But that's not going to get the views. Maybe it is because it's a hot button topic. But so I think what limits the effectiveness of mass changing of minds is just the format. Yeah. And there's nothing you can do about that.
No, I would have.
Your intentions were great going into it, right?
I would love to have the perfect format, but being a family medicine doctor who kind of the principle of which we practice on is risk reduction, not perfection. Yeah. Unlike the biohackers of the world who want to fully optimize everyone's health to the max nth degree, I want to get people to a relative homeostasis that they're comfortable with, whatever that means for them. So before, it used to be that when we would advocate in family medicine for condom use, people would be like, oh my God, you're advocating for people to have sex. They should wait until marriage. How dare you advocate for condom use? It should be abstinence only. And we realized, like, okay, that doesn't work. So let's do condoms and find some risk reduction here. So I would have loved to have the format to have it be perfect. But I'm like, look, this is what I have at my toolkit of this is what people are watching. And I desperately want to reach people with this message. What's the most ethical way we can do it, and see what happens and learn from it. And I think doing the first episode, I realized the situation with the flags, that people could cut me off. So in the second bout, when I went back, I said, okay, now I'm not going to let them vote me out. I'm going to say, hold on, I want to finish my point and be a little bit more proactive and get better at it. And my hope is that young students would look at this and be like, I'm going to do this better next time.
Yeah.
I learned from what he did, but I can do it better. And I think unless we do that a little bit and get outside of the comfort zone and perfection zone,
that's a good
I
point.
think it's going to be hard to learn because we won't have anything to learn from.
No, it's a great point because like, I guess the argument, even if let's say it didn't change any minds, was it still worth it to do it?
Yeah.
And I would argue it is because you're showing people
that there's a way of something
there's a way
happening.
of just having this conversation. You can have this conversation and be calm and not result to ad hominem attacks and, personal things and just anger.
Yeah. Because it would have been easy for both parties to get really angry at each other and just have a Thanksgiving.
That's what I was like, whew, man, like good on you. Like honestly, I was thinking the whole time, I was like, I would not be able to do this very well. So,
and also something that surprised me is in the comment section on the 13 million view one, the comments are largely pro-vaccine, which is interesting because it's on a platform where usually people go in to argue. And while there are some comments that are still standing with the anti-vaccine crowd, the huge majority, and it's not my platform, so it's not like it's my people. Interesting to see positive comments on it. I fully expect it to get roasted.
Do you think we overestimate the size of the anti-vax community just because of how vocal they are?
Yes, but appropriately so. Because it doesn't take a lot to start a fire that spreads wildly. So we need to be very afraid of how, because it doesn't take a lot to destroy measles herd protection. 95% need to be vaccinated for perfect protection. Once we start getting just like a 10% change, which isn't huge. It's still, if you stop most people on the street, they agree. But you lost that percent and now lives are being lost. So you need to be appropriately worried about it. And that's why I hate when the recent Surgeon General nominee is out in front of Congress and they're asking, like, do you believe in the measles vaccine? And they're like, well, that's literally, I think, one of the questions asked. And the answer was like, yes, but individuals, it's like vaccines, when you're talking about them to the general public, this is a public health intervention, not an individual decision. When you're in an exam room, have an individual discussion.
Right.
But you can answer the question genuinely and generally without having to say, but I would do something different in an exam room. I would say Tylenol is great for muscle aches, but it doesn't mean every patient should get Tylenol. You know what I'm saying? Like, but they refuse to do that. And I feel like unless we call it out, we further strengthen their ability to confuse people.
Yeah, I agree. It's, there's a lot to call out these days.
There's a lot to call. What are you calling out in the eye world?
Oh man. I'm always trying to convince people not to, well, from just an education standpoint, like don't sleep in your contacts. Do you sleep in your contacts?
I don't wear contacts.
You don't wear contacts? Okay, good.
I don't like touching my eyeball.
A lot of people don't.
I don't know.
I don't have a problem with it.
Really? You're just randomly in the middle
just
of
touch my, just
get that cornea.
Give my eye a little touch, No, don't touch your own eyeball, folks. I mentioned one earlier is this idea, this wellness, holistic idea that the general idea is just any medical intervention it prevents your body's ability to heal itself. And so you have people that talk about wearing glasses as something that's going to make your vision worse. Like, don't put your kid in glasses. That is like one of the most harmful things that you can say in my world, because a kid comes in who's high hyperopic or has amblyopia. So they come in 20/20 out of one eye, the other eye is like 20/60. So it's like a 4-year-old, 5-year-old. And you have a parent who has seen all this content from people saying, don't eye exercises. That's the way to do it. Like, you don't need, or take this supplement. Glasses are just going to make the problem worse. This happens. And I've heard from parents who come in, they're like, is this going to harm my kid's vision to prescribe these glasses? Like, no, it's actually going to help treat their lazy eye. It's actually going to bring their eyes into alignment by wearing these glasses. And if that message is so pervasive that it gets to these parents and they don't enforce glasses use with their kids, then they'll have a permanent decrease in vision in one eye. And
learning dysfunction, I'm sure.
Yeah. And so it's that's one that really irritates me, because it's just physics. You're just bending light to allow it to hit the retina. There's nothing harmful about wearing correction.
Sure.
Glasses are one of the greatest disability accommodation success stories,
and they've been around
history.
For so long.
Yeah.
Do you know in the
few 100 years? I don't know.
When did the eyeglass?
Well, like Benjamin Franklin, was he the one that invented bifocals?
Sam's fact checking. Yes.
let me know. I'm not sure, but
long time,
long enough. And so,
how did they figure that out?
The glasses?
Yeah. How does it?
Good question.
Like the first person who knew to drink from an udder and who created glasses, same person for me.
Did they ever drink directly from udders?
Gotta ask our old friends.
If you had a farmer on here recently,
no, I did have a vet not too long ago. I should have asked that question.
But yeah, the glasses thing is blue light blocking glasses is another thing that people, and really
they talk about eye fatigue and things that are not relevant.
The problem with the blue light blocking technology is that it's promoted as a cure for so many different eye diseases. Yeah. Like it'll improve macular degeneration, macular health, the overall eye health. No, it doesn't. The only data we have that is for the use of blue light blocking technology is for sleeping, is regulating your circadian rhythm. That's when it can be helpful.
I've had that argument with potential sponsors for the channel where they're like, we want you to, no, it doesn't do that.
It doesn't. But I get asked so often about blue light blocking glasses that I tell people all this. I'm like, we have no data to support that's going to help with your eye strain working on a computer 18 hours a day. But it's not going to harm you. And just, so just kind of let people are going to do what they're going to do. And what I don't want to do is be so anti blue light blocking technology that they're like, oh, I don't think I want to go back to see this person. I need them to be coming back to see me to get accurate information. But blue light technology drives me crazy.
Are there any products that people shill these days that get you fed up?
Oh, there's all kinds of like holistic eye drops.
Oh, really? Holistic eye drops?
Oh yeah, there's the homeopathic eye drops.
Oh,
that's it's homeopathic. So, and you can see these at any over-the-counter. Simulation is like a big brand for that.
What are they?
It's tap water.
That's what's the promise?
Oh,
better vision,
lubrication, better vision, helping you with styes. Whatever. I don't know, whatever it is. But you look at the ingredients. It's a classic homeopathic. Yeah. It's little like
hyper diluted, whatever.
Yeah, things in such small quantities that you're basically just splashing tap water in your eyes. So
which.
I mean,
it's not going to damage someone's eye, right?
Here's one that's happened that's been in the news recently is
the recall.
That
I thought
that's what I forgot about that one. But no, it's with all the protesting going on and with ICE and everything. It's how to protect yourself from pepper spray exposure. Yeah. And one thing I'll tell you, like, don't use milk products. Like that's something I see on social media all the time. Milk is great because it neutralizes everything. No, milk has harmful bacteria in it, especially if it's like raw milk or something, right? But even pasteurized milk still has bacteria in it. And so,
where did that come about? What's the milk angle?
I think it's just because the fats in milk can help kind of emulsify the oil and kind of neutralize it, like capsaicin and just to help with symptoms from it. But if you get pepper spray, you can get corneal abrasions, and then you dump a bunch of bacteria on your corneal abrasions, you end up with an infection, and that's a big problem. So that's been a bit of interesting education recently. get a lot of questions about how to protect yourself from that. Wear eye protection, folks.
Yeah,
That's
and
good.
then tell me about the recall.
Yeah, the recall.
Because it's happened numerous times.
It happens every so often. And this is why, in general, I want people to get the most affordable artificial tears like they can find.
And you hate Visine.
Don't even get me started on Visine, Mike. This is no Visine. Visine, I wish we could gather up all the Visine and shoot it off into the sun and just get
All
rid
of
of it. Visine's never good for you.
Okay,
Yeah.
never.
So no, Visine has it's so any redness reliever. So not just Visine, it's Clear Eyes, Rodo, that like cooling sensation you have when you put Rodo in your eyes. That's a little bit of your eyeball dying. You don't want that.
Oh.
Yeah. So it's
Eyeball dying.
you know, generally, you know, in no uncertain terms, but the Visine thing, it has astringent in it. And so what it does is it's a vasoconstrictor. So it'll constrict those blood vessels, but then once it wears off, comes back worse than before. So you get into the cycle of having to keep using Visine.
So it's the afferent of the eye.
It's the afferent of the eye, exactly. So, you know, will it help you hide your pot smoking habits from your parents? Yeah, probably, but it's not something you want to use for dry eye, any kind of eye problem. And so Visine's a no-go.
Are people overusing it?
Oh yeah, yeah. Every week I get someone that comes in, like, I've been using this, it's not getting better. I have a drawer full of Visine. I keep it.
What's the plan after, like when they're getting the bad rebound? Is there a rehab protocol?
We just stop it and then put them on just a regular artificial tear, hydroxymethylcellulose, like, you know, refresh, sustain.
Any one
blink.
of these antihistamine treatments, or you don't like those? Either?
Antihistamine is helpful for people that actually do have itching, real itching. It's not a good just lubricant to the eye.
Sure.
So yeah, the over the counter, all the antihistamine over the counter drops are pretty effective. Yeah, yeah.
And then where's the recall happen?
The recall happens usually it's with kind of off-brand drops. At least so far, every time we've had a big recall, and it's because they've been contaminated with something harmful. Last one was Pseudomonas.
Great.
Not good. Yeah. I mean, Pseudomonas, one of the worst things you can get in your eye. And so it's why I tell my kids, like, if you're ever in a hot tub, you never submerge your head in a hot tub.
For the fear of
just
folliculitis getting
everything. Just, Pseudomonas, you know, just infiltrating every part of your, you know, when we're physicians, like, we see all the worst things that can happen to the human body. So sometimes we have like unreasonable expectations for our family members.
Well, it's how like orthopedic surgeons, like, I would never ride a motorcycle
or never be on a ladder more than 6 feet or something.
Right. So that's yours. Don't dump your head.
Don't dump your head in a hot tub. Also, don't sleep in contacts. We talked about that really.
And tell people why that's bad.
So sleeping in contacts, it prevents enough oxygen basically to getting to the surface of your eye. And also things can get trapped underneath the contact. You can have bacteria that get trapped underneath there. The contact could start rubbing up against the cornea, creating an abrasion that bacteria can get into. And so you're setting yourself up for an infection. So most of the time patients come in, I see an infection. Yeah, they've been sleeping. Some people haven't taken their contacts out for months.
What's this like TikTok thing if someone has like 50 contacts in or something?
Yeah, yeah.
And why is that happening? Or is that not happening?
So at most I've ever seen 3 contacts.
Wow.
50 is newsworthy.
Yeah.
But that's about it. Like that doesn't happen routinely.
What's your favorite ocular condition to treat?
I mean, it's boring, but cataract.
Oh, why?
Yeah, it's what I do every week. Because it's what sold me on ophthalmology in the first place. Because
quick results.
We the surgeries we do, we can do it in 10 or 15 minutes, if not shorter, and it's not immediate vision recovery, but near immediate, like within a few days. Vision's back to 20/20 ideally.
Wow.
And so it makes a huge impact in the quality of life. I mean, we can take a patient who's, sometimes you can have hand motion vision where all you can see is a hand in front of your face and do a 10-minute surgery, and the next day they're reading on the chart.
Wow.
So and I saw that for the first time as a med student. I was like, I think I could do that for the rest of my career. And so far I have. So
serious question.
Yes.
Don't laugh.
I'm already laughing.
If my dog Bear gets cataracts, will you fix?
Will I do the surgery?
Yeah.
we can right now if he's here. Like let's do it.
Because I see cloudiness already, and I'm getting nervous.
Yeah. So it's funny. I within the past year, I spoke at a veterinary conference, and one of the big pet peeves that veterinarians have is when human doctors think they can treat pet problems.
So wait, is the dog's eye different than a human eye?
Yeah. It's
no way.
It's not. It
looks so similar.
It does.
Which is a dumb guy thing. Taking off the doctor's hat for a second.
I did the same thing though. I got up on stage in front of these people, and I was like, I showed a picture of my dog who has entropy, and I was like, I think it's fine though. And they all groaned. It was like, oh, here's a human doctor trying to tell us about animal ophthalmology. But actually, when we learned how to do cataract surgery, we use cow eyes. To like learn certain parts of the procedure, which is also very different. But the basic anatomy might be similar, but how that anatomy works under the knife. So I could
wave the
I could wing it. I could wing it.
Okay.
Yeah, I don't think you'd want that though.
Yeah, I want it, and we're gonna do it on social media live stream because
stay
who
tuned,
needs
everyone.
ethics?
That's right.
Thinking back across your medical training, what's the craziest case you've ever had?
One that was kind of a sad case was a patient, an elderly woman who came into the emergency department with an orbital cellulitis. And so orbital cellulitis is when you get an infection behind the eye in the orbital space. And that is there's not a lot of things that'll bring an ophthalmologist in the emergency department, but that's one of them. And those patients will get admitted to the hospital. And the question is, what kind of organism is causing it, right? And that can really affect how severe, how quickly this will progress. This patient, orbital cellulitis it's uncommon, but common enough that I've seen a handful of cases over the course of my career so far.
I've prevented some by treating preseptal cellulitis.
There you go. Yeah, that's a big thing. Good job. Yeah. Nice. And knowing the difference between the two. I get a lot of orbital cellulitis referrals that end up being preseptal, but so it can be difficult to establish.
But sometimes it's subjective to some level. With the patient saying that there is a lot of orbital pain and...
Right. Yeah. So the biggest differentiating factor is the presence of orbital signs. So that means things that are happening in the orbit that'll manifest on exam, like the eye having proptosis, so moving forward, having pain with eye movements is one of them, or diplopia, having double vision because there's so much inflammation back there, the eye's not moving in the way it should, pupil abnormalities. So yeah, those are the separating factors. Most of the time it is preseptal and we can treat it with oral antibiotics. But in this case, the patient was admitted and we were just, all thinking like, what, how could she have gotten this? Could it, you think about all kinds of things like IV drug use can cause orbital cellulitis, certainly trauma or, any kind of like a bite on the eye or something. And then after about, a day of, treating and thinking about this, she said, what's interesting? My cat had the same thing who died. And so she showed a picture of her cat. It had the same appearance to that cat's orbit. That cat had orbital cellulitis and had been sleeping with the patient. And so she got her orbital cellulitis from the cat. And through that, we were able to, we did some investigative work to figure out like
what kind
of bacteria can kind of, cross-pollinate between species and able to get it treated. And she survived. She actually ended up having to lose her eye from that infection, which is, something that can happen with an orbital cellulitis, but she survived. It was a disease that can be fatal if you don't kind of treat it effectively enough.
So be careful of cats.
I would say if you're, maybe if your cat has a serious eye infection,
create a little barrier.
Yeah, a little separate living quarters.
Treat it like a conjunctivitis. Don't share makeup with your cat.
That's right. But some of the most satisfying cases I've seen a handful of melanoma, and the way we treat melanoma in the eye, because you have pigmented tissue in the choroid, which is behind the retina. So it's all pigmented back there, and you can get a melanoma affecting that tissue. The way we treat melanoma in the eye is create a custom radioactive plaque that you suture onto the surface of the eye that provides focal radiation, kills the tumor. You leave it on for a few days, and then you take the plaque off.
Wow.
And that's ideally all the treatment the patient has to have. Really cool.
That's wild.
Yeah. It's only a few people,
That's very heavy.
not a lot of people around the country.
And
do that kind of
melanoma,
work.
I remember when studying it in med school days, it spreads to unusual places like the eye. It has a reputation for unusual spread.
Yeah, and these are typically primary melanoma. So we saw it a lot in Iowa. That's where I did my residency training. So, and honestly, we don't know a lot about why Iowa is such a hot spot for melanoma. It's actually an ongoing, you would think it's sun exposure, but actually there's very weak association between UV exposure
And I would think why
choroidal
Iowa?
melanoma.
Yeah.
So other types of melanoma, iris melanoma, eyelid melanoma, that's more associated with UV light, but not the choroid. And we don't really know why Iowa is such a hot spot, but we saw so many cases of melanoma there.
Who knew?
Yeah.
For our current generation of peoples, what are some habits that we're doing that we shouldn't be doing that are hurting our eyes?
We really need to stop looking at our phone before we go to sleep for an hour.
Okay.
I just did it last night, so I'm guilty just
Sure.
as much as anybody else, but I am.
Because of the blue light and sleepiness, or are you thinking more?
That's part of it, but also more just dry eye.
Oh, okay.
Yeah. So we've had studies that have shown that screens hold our attention so well that we don't blink. Our blink rate goes down. And so dry eye just gets more common as you get older anyway. By the age of, I would say 60, like virtually everybody has some degree of dry eye. And when we're sitting in bed or anywhere, just looking at our phone right before bed, sure, it affects our sleep, but also it'll just exacerbate dry eye symptoms. And so I'm always telling people, taking breaks. Like sometimes you have to like police yourself on this, right? Like honestly, every 20 minutes, you should be looking away from a screen for like 20 seconds. And you want to look in the distance to be able to relax your accommodative focus. And so the 20-20-20 rule, basically. So every 20 minutes, look away for 20 seconds, 20 feet away. And that'll allow you to relax your eyes and just kind of a stimulus to blink and then go back to, doom scrolling on your phone.
Sure. Which is great for sleep and your vision. And then what's a thing we should be doing that's positive that we can improve our eye health?
It's just basic stuff. I think everybody should every once in a while do a hot compress. You know what that does? It heats up the meibomian glands and helps lubricate your eyes better.
I have that dysfunction, actually.
Oh, do you? Yeah. You got a little MGD, a little meibomian gland dysfunction. All right.
I'm a little embarrassed.
It's okay. You and like 100 million people have meibomian gland dysfunction. I can't tell you how many times a day I talk about meibomian glands.
It's tough.
I should have been Dr. Meibomian. I don't know why.
That's a good title, too. That's a good one.
I could have gone with that. But it's like basic things like maybe, doing a hot compress, not being afraid to use artificial tears, taking, screen use in moderation whenever you can, taking breaks, but all these things will improve like your general health too, right? Exactly. Like getting up from your desk, every so often, just eating healthy, sleeping better. If you wear contacts, diligent contact lens hygiene is so important. That'll prevent so many bad things from happening. And, using them the appropriate amount of time. I wish everybody could be in daily contacts or use contacts because dailies are always going to be a little bit safer, but they can be expensive, but just, not sleeping in them. That's the biggest thing.
Yeah. So we got to take care of our eyes.
Take care of your eyes. They're important. And, don't go to chiropractors.
I love that. That's your take home message.
Seriously.
Where did that start? Where did this?
Man, the algorithm is so effective on TikTok in particular that as soon as you get mad and watch an entire chiropractor video, you're going to get so many of them. Yeah. And the stuff I see is so dangerous that, forceful neck manipulation if you end up with a vertebral artery dissection, that could lead to an occipital lobe stroke, which can give you a homonymous hemianopia, which would lead you to my clinic where we might have to talk about not driving anymore.
Sure.
And that's one of the hardest conversations as an ophthalmologist that I ever have, is when I see a patient who's had a stroke come in, do a visual field test, and oftentimes they don't really recognize how much vision they've lost. But they've lost half of their vision. And in, I think, every state, you have to have a certain degree of visual field in order to qualify for a license. So like patients get angry, talking about this because I'm taking away, their ability to drive basically. And it's hard. It's challenging.
It's really challenging. And I'm curious because this threw me for a loop with one of my last podcast guests. She's a YouTuber, very famous. She happens to be blind. And she very outspokenly to me told me that she does not, even if there was the ability to cure her blindness, she does not want to be cured. Is that something you've come across with people who have issues with vision? And is that what you would have expected someone to say in a situation like that? Have you ever heard of that?
No, I can't say I've ever had that.
I was really
conversation.
surprised as well.
That is a bit surprising. I think it would change. I think it would depend on how long someone's been blind.
Well, yeah, she grew up.
Right. If that's your life, that's what then I think that's very different than patients who lose vision from a disease.
Yeah, because I think as a doctor, if a patient comes in and they're blind and there's a potential treatment for them, I would say, let's do it. But that's not my job.
Right. No, let me do that. Yeah.
Well, meaning it's not even our job. Our job is to present the option.
Oh, yeah.
And then actually ask if they want it.
Right.
Which we sometimes lose track of that.
Well, and that's a good point because I frequently have these conversations. Like probably the biggest source of blindness that I see is macular degeneration. And patients can slowly lose vision over time. And it does get to a point, some patients really want everything you can do. Like we have new treatments that are coming out all the time with macular degeneration. It's actually a very exciting field in ophthalmology. And we have retina specialists that do that type of treatment. And we have clinical trials and all these things. And some patients are gung-ho, like, yes, that like, I'll, let me know, like I'll try anything. But some patients who are count fingers, they can't see, certainly not well enough to drive, but they are functional. Like they can do all the things that bring them joy that are like, even if it would make me feel better or make me see a little bit better, I don't want to go through all that. I don't want to go through injections. I don't want to go through treatment. Because that's when we're talking about, these types of eye conditions, that's a lot of appointments. Yeah. And so there's people that go for it, but a lot of people that are content, they're happy, they have a support network, and yeah, they don't want to pursue.
Do you hate LASIK?
Oh, LASIK's an interesting one. Are you asking because I'm not wearing glasses right now?
No.
Guess what? I've never actually had a dedicated dilated eye exam.
So you're a bad person.
Don't tell anybody.
I think you
don't have a very big platform, do you? Is this
what platform? You're just talking to this microphone and no one can hear. You're screaming into the ether.
LASIK it's a good procedure that's helped a lot. There's been 40 million.
I feel
LASIK.
a politically correct answer.
No. Well, maybe a little bit. No, it's a good procedure. It helps a lot of people. But there are a lot of people that have been harmed by LASIK that are very outspoken, against trying to convince people not to do LASIK. For LASIK, it's very important that you do your research in terms of like seeing someone who's got, look at the reviews, because this is a cash pay procedure, so you're taking a 20/20 perfectly healthy eye with glasses and you're doing a surgery. So you're putting those eyes at risk of a complication. Now the complication rate is very low, like 0.5% roughly. And so if a patient is interested in it, I absolutely refer them to my partner who does LASIK procedures because it can make a huge difference in someone's life. But the risk is real of chronic dry eye, A very, very small percentage of patients have debilitating pain after LASIK, like very small percentage. And so you have these conversations. This is why you do informed consent, especially for something like LASIK. And so, yes, it's a very good procedure that helps people. Patient selection is key, and outlining the risk and benefits. But unfortunately, there's a lot of like LASIK mills, a lot of people that
there's a lot. That's why I was going to bring up these farms where it seems like they do 40,000 procedures a year. And I'm like, how did you do that and have informed consent?
Exactly. And so that's why understanding what you're getting into as a patient is very important with something like LASIK, and doing your research. Don't be afraid to get a second opinion. I would honestly recommend anybody who's willing to shell out the money for LASIK, get a second opinion, and make sure everything seems up to board and you feel comfortable with the doctor who's doing it, and that you actually see the doctor who's going to be doing it before you actually get under the laser.
For sure. What's a treatment? Is it maybe surrounding macular degeneration that you're most excited about on the horizon in the ocular space?
Yeah, I would say gene therapy is really interesting. And, I don't personally do that work. I am a comprehensive ophthalmologist. So if someone qualifies for any kind of treatment, certainly like something like gene therapy, which we are starting to have gene therapy for certain inherited diseases like Leber's congenital amaurosis, very exciting things, which can potentially restore vision in the future. I think that's probably the cutting edge thing in ophthalmology. Macular degeneration is great. For a long time, we only had treatment for the wet form of the disease, and the dry form where you get these big patches of atrophy in your retina. You basically just lose retina. Didn't really have much we could do about it. Now we actually have treatments that can stop the spread of that.
Wow.
So we're not at the point of eyeball transplants, but lots of exciting stuff there.
And then what about for yourself? What's the biggest breakthrough for Will?
My defibrillator hasn't gone off.
Good.
Knock on some wood there.
Because I saved the hard questions for the end.
That's right. I think it's been so much fun really getting into and trying to make a difference in like the healthcare system, like advocacy.
Why does it sound like your eulogy right now? You're supposed to talk about the future. You're like, it's been so much fun.
Oh, yeah. I'm done now. See you, everybody. You're not going to hear from me ever again. No. Okay. So like going forward, I'm not a very future oriented thinking person.
Yeah, you are.
I don't, kind of, but
I want to get excited. We've talked about the doom and gloom of Pseudomonas in the eye. And
I'm working on a book.
Ooh.
Yeah. This will be a kind of like a Glaucomflecken's guide.
So it's going to live here.
Yeah, I'll put it right here for everyone. Kind of like a Glaucomflecken's guide to medicine. So it's going to be more humorous, bring in the characters and just kind of levity, and I think it'll be a great book for anybody who's
That's exciting.
So that's fun.
Tease.
That's fun. Working on, my wife and I have a live show that we do called Wife and Death, where we talk about our story. And I give credit to her. She came up with the name. And and I want to do another show. I'm currently writing it just about healthcare system, which sounds hilarious, but I'll try my best to make it funny.
I'm pretty sure it's really good.
I love performing. That stand-up comedy kind of background has never really left me. So I love speaking and getting on stage and doing fun stuff like that. Yeah.
And where can people follow along the journey?
Oh, I mean, everything I do, my website, glaucomflecken.com, it'll
Which
end
is
up
easy
there.
to spell.
Yeah. Very simple. Just spell just like it sounds. It's easy. You can find everything there. Okay. Our podcast, obviously, Knock Knock Hi.
Which I've been a guest on.
Yes, you have. Yeah, you're one of our first guests. We got to have you back on too. Yeah.
What's going to be our conversation V2?
We're going to have a live boxing match.
Oh, between me and.
Oh, I don't know. Not
RFK?
me. Me? No. I'll just moderate it. How about that? No, I don't know. But Knock Knock Hi with the Glaucomfleckens. That's about it.
Awesome. Well, I hope you had fun.
Yeah, this was great. Thank you.
On the checkup, getting the full body exam.
That's right.
Click here to listen to my interview with Molly Burke, the blind YouTuber who doesn't want a cure. And as always, stay happy and healthy.